Assalamualaikum. I'm Dr. Tahira and you're watching program Health is Wealth on PTV World. It is November, which is also called Movember. We are celebrating men's health and we just celebrated International Men's Day. And why not talk about men's health, all the problems associated with men, surgery and their management. So let's watch today's program on Health is Wealth. Assalamualaikum, I'm Dr. Tahira. Welcome to another episode of Health is Wealth, and today we are discussing, because it's November, men's health and everything that's related to men's health along with surgery. When we speak of surgery, there are different kinds of surgery, and now we don't need to cut open anybody anymore. We can actually go through a camera. So why not speak about laparoscopic surgery, the less invasive, the easier thing for the patient that should be much better. So we have with us a very notable surgeon, general surgeon as well as laparoscopic surgeon. He has done a lot of innovations in gynecology as well as male infertility. Thank you so much for joining us, Dr. Adil Shafi.
Thank you very much for having me.
All right, so let us start with, why is laparoscopic surgery the new thing? How is it different from conventional surgery?
Well, let me tell you the laparoscopic surgery, which is famous among the public with the name of laser surgery. Actually, there is no involvement of laser there, but it is about the minimally invasive surgery. Otherwise, you can also call it as keyhole surgery. It is different from the open conventional surgery in terms that we make small holes. Through that small holes, we put in a camera and then we can visualize whole tummy. Okay. The first step is we put in the telescope, we survey whole abdomen, that is called diagnostic laparoscopy. Okay. Means with less than 1 centimeter hole, you can visualize the whole viscera of the tummy. Okay. That is one beauty. The another thing why it is superior if we compare it with the open conventional surgery is because small holes, after 3 months, there will be no scar mark. Yeah. So better cost message. The another advantage we are having so far the laparoscopic surgery is concerned, the same day we admit the patient, same day we operate, and same day in evening. If we operate patient in the morning, he will be discharged by evening. So shorter hospital stay. Right. By having said this, shorter hospital stay, then which means less involvement of the money, economical. Right.
Exactly.
Fast recovery. Right. Fast recovery, the other day he or she can resume the daily routine activities.
There's no bleeding as well?
There is no bleeding. I mean, when you say the no bleeding, the surgical hand, the hospital matters a lot. Right. The another advantage, it is giving you magnifying image.
So that you can see on the screen.
So there are less chances of injury and complication. Right. So less chances of complication and injury, for that matters the laparoscopic tower where you are operating and the skilled hand as well. What you can see with your naked eye, it gives you 10 times bigger vision than the naked eye. Right. And one difference in the laparoscopy and open surgery is, when we put in a camera, we are not directly focusing towards the tummy, but it is on the monitor where the image is being displayed. Okay. In open surgery, we are directly looking into the tummy. Right. The another beauty that laparoscopic or minimal or keyhole surgery is having is less chances of wound infection. Right. And less chances of having the hernia after the surgery. Right. So these are the benefits in terms of the patient, in terms of the surgeon.
That is a very good thing, that it's economical and the patient does not have to stay in the hospital for long. There is no infection, no big gaping wounds and everything. Yes. But how many hospitals in Pakistan are actually offering good laparoscopic surgery so that more and more patients can avail it? And who are the doctors involved? Like, what should a doctor's qualifications be to be able to perform specific laparoscopic surgery?
For a skilled laparoscopic surgeon, it's a long journey. I mean, it's a very long journey. the learning curve is very long if you compare it with the open conventional
Where did
surgery.
you do your, laparoscopic surgery?
Yeah, previously I used to be at Maroof International Hospital. I spent 12 golden years there. And then I joined Advanced International Hospital. Recently, I am working as a laparoscopic surgeon at the Premium International Hospital, Islamabad, at the Umar Diagnostics and the Shahid Khalik Hospital. And I have a lot of gynecological colleagues which used to be at Medicare Hospital, Rawalpindi, one of the leading gynecologists, Professor Rizwana Chaudhary.
So when we speak about this laparoscopic surgery, can you mention the different kinds of laparoscopic surgery that are available, which you are performing?
So far, my specialty is concerned, the surgery. The most common surgery we use to perform daily basis, and we used to say it is a bread and butter of a surgeon, is the gallbladder disease.
Okay, so
By saying-
cholecystitis.
By saying this gallbladder disease, you can have gallstones, gallbladder polyps, early gallbladder cancer, which is confined to the fundus of the gallbladder, and then the inflammations of the gallbladder.
Okay.
So this is the common procedure. The second
So
procedure.
let us first start with gallbladder. We'll go
Yes.
step by step. When
Yes,
we
yes.
speak about cholelithiasis or
Yes.
cholecystitis,
Yes, yes.
when is surgery an indication?
Yes.
And what are the different, symptoms of this disease? And, can it be controlled by medically or should we go for surgery?
So far the gallstone disease is concerned, the worldwide consensus about the gallstone or the gallbladder polyps or the cholecystitis is the gold standard treatment is laparoscopic removal of the gallbladder, which we called as laparoscopic cholecystectomy. Previously there were two school of thoughts. The one school of thought was saying like this: if the stones are asymptomatic, just you need to avoid fatty, spicy, and oily foods.
Okay.
And there was medicine trial as well with the name of some medicines, ursodeoxycholic acid and the echinodeoxycholic acids. But then the consensus was made that it is associated with some complications that at times can be life-threatening. Like I mean by saying this, I mean to say this stone from the gallbladder can slip
Okay.
and it can block the main liver duct, which we call as common bile duct.
Okay.
So if it blocks the common bile duct, then the patient presents with severe pain in the upper abdomen.
Okay.
He can present with the yellow discoloration of the sclera, dark color urine, then change in the stool color. By saying this, I mean clay colored stool, then pleuritis,
Okay.
generalized itching.
Yes.
So these symptoms, painless jaundice, we guess that this is having obstructive jaundice or surgical jaundice.
Okay.
So one of the complication. Second complication that one can have if it slips from the gallbladder, that it can block the common door. Which common door? Where the liver and the pancreas meets and they open into the second part of the small intestine.
Okay.
So when it blocks that door, it gives rise to the pancreatitis as well, which is more dangerous in comparison with the obstructive jaundice.
Right.
In that scenario, we cannot operate this patient.
Oh, okay.
Like regarding the pancreatitis, I can talk about 2 hours about the pancreatitis, but one Indian author has summarized it beautifully.
What did he say?
He says it stings like a scorpion, which means it produces severe unbearable pain.
Okay.
It drinks like a fish, which means it causes severe dehydration.
Okay.
It burrows like the rodents, which means it causes the abnormal communication. It eats like wolf, it causes necrosis of the pancreas. And it kills like a leopard, it is a life-threatening disease.
And we don't even
Because
take it
gallbladder
seriously.
stones, they are associated with the life-threatening complications. So even if this is incidental finding, nowadays the consensus is one should be discarding this bomb which has no time when and
Detonate.
how this
Yeah.
is going to explode.
Right. So then we go for a cholecystectomy.
Cholecystectomy.
So when we say that we're going for a cholecystectomy, people are scared that once the gallbladder is taken out, I don't know what their life will be normal or not. So how does their life change? What is the precaution or management they need to take after a cholecystectomy? And also, how long does a cholecystectomy take now, and how long is the recovery rate?
Yes. There are facts, there are theories, and then there are myths
Okay.
existing in our society that without gallbladder you cannot eat these things for rest of your life.
Right.
Without gallbladder you are going to get fatty, which is never in actual practice.
Right.
I mean, the commonest surgery I just mentioned is the gallbladder removal surgery. Some people, they are born with absent gallbladder.
And they're
Some
living?
people, they are absent. They are born with absent appendix.
Yes.
One Indian surgeon has operated on patient who was having 2 to 3 gallbladders.
Oh,
Sometimes, so anatomy matters.
Right.
So sometimes it is normally on the right side, sometimes it is on the left side.
Okay.
So cholecystectomy in safe, expert hands is a very smooth procedure,
Okay.
is a complication-free procedure. In a straightforward cases, by saying this, that you are having discomfort in the upper abdomen and you are diagnosed with the cholelithiasis, you are not complicated with the jaundice or the pancreatitis, it takes about 30 to 40 minutes.
That's it.
Yes.
And you're out. Okay.
And the second day you resume your routine activities. It is so simple.
So that is very good. Everybody around here who is listening to the program or watching it should know that if somebody is suffering from these symptoms, instead of going that other route, they need to go immediately for a cholecystectomy and not worry about it.
I want to mention here, don't listen to the people who are not concerned about.
Yes, the doctor. Just
Yeah,
listen to the.
Listen to your surgeon.
Right. Exactly.
I mean, I have a 15 years of experience. I am saying because I have operated about 4 to 5,000
Right.
gallbladders.
Yeah.
So you live absolutely normal life after the surgery.
Okay.
There are some organs in the body, those are vitals, which means without those viscera or organs, life is not
Yeah,
possible.
but then there are vestigial ones.
Then there are, being a Muslim, I cannot say that vestigial, but I would like to say non-vital organs.
Okay.
So many people born with absent appendix
Yeah.
and absent gallbladder,
Yeah.
so they live absolutely normal life.
Speaking about appendicitis, what are the symptoms of appendicitis? How fast should one act? And how do we go about it? How long is the procedure? What are the complications if we ignore it, if we go to some quack and he delays it or just gives some painkiller?
Appendicitis simply means the inflammation or the infection of the appendix.
Okay.
It is just a worm-like structure, a tubular structure, which is present at the junction where the small and large intestine meets. Okay. Usually there is a valve which is called valve of Gerlach. That valve of Gerlach, when it is competent, so there is no possibility of any stool that can get into the
Okay.
appendix. The people who consume more junk foods, they can have it. And coming to your question,
Yeah.
I mean, the ideal treatment once you are diagnosed with the acute appendicitis, early diagnosis, early treatment, best results.
Symptoms of appendicitis.
Yes. Coming to the symptoms of the appendicitis, usually people experience pain around the belly button initially.
Yeah.
Then it shifts from here and it gets localized into the right lower abdomen.
Okay.
And sometimes when we ask question that how it gets aggravated, by walking, by coughing,
Okay.
by turning around, it gets worsened.
Okay.
On coughing, it gets worsened.
Okay.
Sometimes the other symptoms one can have is the nausea and vomiting, anorexia, which means loss of appetite, and at times fever.
Okay.
Fever, we guess then it is maybe early perforation or perforated appendix.
Right. So when we speak about appendix, there were a lot of signs that we used to look for as a doctor: rebound tenderness, and that
Yes, yes.
you know that it is there's. What are those signs? Can you mention a few so that
Yeah,
people
yeah.
know if that a doctor is examining you right, and the
So if a-
investigations you need to go
Yeah,
through?
so if a patient is coming to
Yeah.
me with suspicion of appendicitis, so first I am going to ask definitely for the symptoms. After I would like to go for examination, just you mentioned. So first of all, I will ask patient to cuff please, and I will ask him to locate with your index finger if you are having any pain
Right.
anywhere on cuffing. So usually he points in this right here in the right lower
McBurney's
abdomen,
point.
yeah,
Yeah.
McBurney's point.
All right.
Okay, so this is cuff sign positive.
Okay.
Otherwise, we called it as Dunphy's sign as well.
Okay.
Okay, the another sign. I mean, we will be just pressing this right lower abdomen, then we'll be having guarding over here.
Okay.
The muscles
Will
get stiff,
okay.
stiff,
Yeah.
and then the patient experiences pain.
Right.
Okay, and when we release the pressure, again he or she is having pain. That is called rebound tenderness.
Right. And what are the investigations you need to do?
Uh,
Just clinical, or do we need any
to
other?
diagnose the appendicitis is a diagnostic dilemma.
Right.
No investigation is 100%
Oh,
to
suggestive.
exclude that this is not appendicitis. If some investigation, which is gold standard nowadays, is CT scan abdomen with IV contrast. But usually we go for the routine blood chemistry like blood CP,
Right.
then urinary, and then we go for the ultrasound abdomen and pelvis, especially in case of females.
Okay.
Those investigations are not actually meant to diagnose the appendicitis, but to rule out the other pathologies that can present in a similar fashion.
Okay.
But if there is something gold standard, that is CT scan.
So now
abdomen.
appendicectomy is also available laparoscopically. So we don't have to do all those big incisions that we learned.
Only 3 small holes,
And that's it.
and after 3 months, he or she has to tell that somebody operated on me for the appendicitis.
Okay, very
Yeah.
nice. Now let's come to hernia, a very,
Yeah.
very common presentation in our part of the world, and people after build either they're lifting weights or even if they are not, they have all sorts of hernias, inguinal and then incisional and then gastric. So can you mention the different kind of hernias, how common they are, why is it caused first, and then
So the most common hernias. So for the male gender is concerned, are the groin hernias, are we called as inguinal hernias.
right.
So for the female gender is concerned, the most commonest hernia is umbilical or the paraumbilical hernia. So the reasons why males are having more inguinal hernias, because their routine work to carry heavy weight,
Right.
heavy exercises,
Right.
okay, these predispose them to have the groin hernia,
Okay.
and then the smoking, which is more found in the male gender in
Right.
comparison with the female.
Okay.
So for the paraumbilical hernia or the umbilical hernia, it comes the matter of pregnancy.
Okay.
So you can
Yeah.
understand.
Yes. Right. What about incisional hernias? Why do we have so
Yeah.
many cases of incisional hernia?
Lot of reasons for the incisional hernia can be from the surgeon side as well. Surgical fault can be patient related factors. Let's say for suppose incisional hernia is we operated for something else, and then at that scar we are having hernia.
Right.
So that is called as incisional hernia.
Right.
That can be faulty surgical technique, and that can be because of some patient factors like obesity,
Right. And loose
smoking,
muscles. Yeah.
chronic cough,
Right.
constipation, and then profession like where he or she has to carry
Lift
the
weight.
heavy.
So when we
weight.
speak of this protrusion of the contents from inside to the outside, right?
Yes.
And they say that there is a chance that it might strangulate someday,
Yes.
and before that you need to fix it. So many people are, okay with it coming out and going in and hanging it, and they're having it hanging outside without realizing how dangerous is it. So can you please, stress on how early the diagnosis is better, and then getting it fixed. Either you remove it or you repair it or you put it in and then you seal that place. How important is
I
that?
mean, it should be fixed timely.
Okay.
Unnecessary delay should be avoided.
Okay.
If patient is operable, there is no contraindication for the anesthesia.
Right.
he or she should get operated timely. Why? Because there are chances, like you mentioned, it can get obstructed, it can get incarcerated, it can get strangulated. So if a patient is having just bulge over the groin or the paraumbilical region, and how we diagnose that he or she is having the obstructed or strangulated hernia, most of the times during coughing or sneezing, it can get obstructed, it can get strangulated. So the most common content in case of the groin hernia is the small intestine. Once it gets strangulated, it just arrests that loop of small intestine. Then it can turn into gangrene.
Right.
Having the simple procedure where we just give nick, we just close the hole, then we place
Mesh
the
on
mesh,
it.
mesh on it to make it more strengthened. Then we have to cut that part of gangrenous part of the small intestine. We have to either bring it over the skin, or we have to suture it.
When we talk about mesh, are these meshes safe? Do they get infected? Is there any post-op care related to mesh? And how long does a mesh last? And how important is it to wear some kind of, truss or belt afterwards on the abdomen or that area?
Usually mesh, a good quality, a low weight mesh is usually advocated, and they are usually safe. But I mean, it's matter of sterilization again, and it is again matter of patient related factors, like how well he is following the advice of the patient, of doctor after the surgery. And I mean to say, is she diabetic, she is running with the uncontrolled diabetes. These are the patient related factors that matter so far the mesh infection is concerned. I have a 12 to 15 years of experience. I can say it confidently. Until now, I never found any of my patients get it infected.
So what is, some people have heartburn and they can't even if they eat something, it starts coming towards the top, and they find out that there's a gastric hernia, right? And then there's a process, something you call fundoplication, right?
Yes.
So what exactly, how does that work? And how do you fix it? And if somebody has symptoms of that, how do you fix that?
Well, by saying this, it can be hiatus hernia. I mean, there is a curtain which we call in medical terminology diaphragm, that separates your abdominal and chest cavity. Okay, sometimes there is natural opening in that natural curtain in that diaphragm, that is called as hiatus. Sometimes that gets enlarged, then the esophagus and the stomach, they get pulled up. Then they are having symptoms just you mentioned. We just fix them laparoscopically, and if it is small hernia, which means it is less than 4 centimeter, we just suture it. Or at times, if it is more than 4 centimeter, we can place in a mesh there as well.
When we talk about the intestine, what are the different conditions? Like, is there an intestinal blockage, like intussusception, or some part of the intestine, like you mentioned before, gets gangrenous, or there is a tumor, for example, a colon cancer? Then what are the chances of doing a laparoscopic surgery for resection of that tumor or whatever infected part or obstruction? And how long does that take, and what are its symptoms primarily?
See, if a patient is diagnosed with small or large intestine cancer, that we our team and myself, we are doing routinely those procedures with laparoscopic as well. And so far, the obstruction, one of the obstruction can be because of the tumor, and when they come to us with the obstruction, having the tumor, so it is only advanced. So there are certain criteria for laparoscopy and open surgery. And just you mentioned the word of intussusception. It is nothing but invagination or telescoping of proximal part of the small intestine into the distal that blocks the...
and that is also possible?
That is possible. I mean, I have done many cases laparoscopically.
And children, it's very common in children?
Very common.
And how good is laparoscopic surgery for children? Do you have cameras that fit their human size?
Usually in case of children, age matters. preferably he should be 5 or above 5.
Okay. Okay, coming down the track, what about these things like hemorrhoids or fistulas or fissures? Because they're very painful conditions.
Yes, yes.
People keep getting them misdiagnosed and mistreated by number of quacks, and they're following
Yes.
so many procedures. So how exactly do they present, and what are the surgical options available for this piles or hemorrhoids and the rest?
So far the piles are medically you can call as hemorrhoids.
Right.
I have my own research regarding the treatment of the hemorrhoids. Hemorrhoids are piles, they are nothing, but they are the abnormally dilated blood vessels over. The predisposing factor is common predisposing factor, especially in our society, what we have injected in our culture
Yeah.
is westernization in our food.
Yeah, processed diet
Yes,
and
the less
refined
fiber
flour.
diet you will be consuming, the more chances of constipation. For every human being, he or she has to strain a bit for stool and for the urine.
Right.
So when you are having hard constipated
Yeah.
stools, there comes the matter of unusual straining.
Right.
So these veins at that place get swollen. Then it is easy to rupture while passing the stool and patient experiences bleeding. Most of the time patient presented in our OPD with fresh bleeding that is painless,
Right.
which is little in amount. This is the common presentation. So then there are internal hemorrhoids or external hemorrhoids or piles. So the internal hemorrhoids, they are further divided into the degrees or grades. So if we talk about the first degree hemorrhoid, the patient just experiences painless, bright red color, bleeding few drops, nothing else. So the treatment is just dietary modification and avoid the sedentary lifestyle.
Right.
Coming to the second degree piles or hemorrhoid, apart from this bleeding, which he or she experienced, we mentioned in the first degree, then there in addition is feeling of something coming out from the anus.
Right.
But that is reduced spontaneously. So in addition, in second degree, in addition to the dietary modification, there is OPD based procedure, which is absolutely painful procedure,
Okay.
that is called rubber band ligation.
Yes.
Then third degree hemorrhoid, feeling of something coming out from the anus,
Doesn't go
not
back.
reduced spontaneously, you have to reduce it manually.
Right.
Again, we can apply the band or the laser hemorrhoidoplasty is one of the answer. Okay,
Right.
I mean we can operate right now. After 4 hours, patient will be discharged.
Okay.
If it is 4th degree hemorrhoid, means it does not go back with the manual reduction.
Right.
Then answer is the hemorrhoidectomy.
Okay.
Or if even you are having the external hemorrhoids, external piles, then answer is hemorrhoidectomy.
Right.
How you can say that this is internal or external hemorrhoid? The length of the anal canal is 4 centimeter.
Okay.
We draw an imaginary line at the 2 centimeter,
Okay.
which we called as dentate line.
Okay.
So above this line, the hemorrhoids, those are originating from above this lines
Internal.
are internal.
Right.
Below this is the external hemorrhoid. Now, conventional Millie-Morgan hemorrhoidectomy is no more practiced nowadays because it is painless,
Okay.
late recovery. Sorry,
It's painful.
It is very painful.
Painful,
It is
yes,
a
yeah.
Millie-Morgan conventional hemorrhoidectomy is very painful,
Yeah.
and the recovery time is
Very long.
very long.
Yes.
I have research
Okay.
which is ligashore assisted pedicle coagulation.
Okay.
I just seal these
blood
hemorrhoids
supply?
with laser.
Okay.
Yes.
And is it similar to that halo method that they say?
Halo is a different way of doing
Okay.
it. That is more expensive.
Oh.
Yeah. Then this ligashore assisted hemorrhoidectomy. Then there is laser hemorrhoidoplasty as well.
Okay.
So the superior among all these procedure is ligashore assisted
So
pedicle
one should
coagulation.
go for that if
Yes.
they have hemorrhoids. What about these anal fissures and fistulas? Do you need to get them fixed because people are roaming around with cytons
Anal
inside?
fissure is nothing, but it is a longitudinal cut.
Okay.
Again, the main culprit is the constipation. Okay.
Straining, yeah.
So usually this cut occurs at a position of 6 o'clock or 12 o'clock, most commonly at the 6 o'clock position.
Okay.
And we call it as acute and posterior anal fissure.
Okay.
So actually when this cut happens, the muscles, the sphincters go into the spasm.
Yeah.
They catch the blood supply.
Okay.
When they catch the blood supply, patient experiences pain.
Right.
That pain is ischemic in origin. We have to break this vicious circle.
Okay.
So we initially we prefer medication. Many a times patient get benefited with the medication. First you have to avoid the constipation by consuming more fiber diet, then one GTN cream and painkiller like that.
Dr. Saab, since we are talking about men's health today and in
Yes.
detail, so let us talk about the problems of male infertility
Yes.
and how surgical procedures can actually help that, because a
Yes.
lot of our patients suffer from like erectile dysfunction or
Yes.
some kind of problem where they cannot produce children or even perform
Yes.
normally. So how do you deal with those conditions?
This is a very interesting and very important question. This is nowadays, I mean, more common problem so far the male population is concerned, and it is go on increasing.
Yeah.
And one of the main contributing factor is the diet. Second is the stress. So you need to have control over the proper healthy diet, and you need to maintain healthy lifestyles.
Right.
These are the main. There are so many other factors that are involved, but these are nowadays considered as one of the most common factors that are involved. Then there is physical fatigue. If you are having physical fatigue, you cannot perform
Exactly.
well. Okay. So for the premature ejaculation, erectile dysfunction, those are concerned. There are a lot of factors
Right.
that need to be addressed. Yes. Sometimes I need to mention, sometimes people get involved in different activities, false activities. So they need to
Refrain
counsel
from that.
themselves.
Yes.
Yes.
And what are the surgical options available to improve it?
One of the common surgical procedure I am doing when I encounter patient with the male infertility, most of the time they are presented with varicocele.
Okay.
Varicocele is nothing but it is the abnormal dilatation of pampaniform plexus.
Okay.
Network of veins, bunch of vessels over the testes.
Okay.
When they get abnormally torted,
Okay.
distended.
So is it
then
same
there
like testicular torsion, or is that
No,
different?
testicular is something else.
Okay.
So these veins, they get swollen, they get twisted, and patient complains vague discomfort,
Okay.
and he just complains, I have a feeling of bag-like worms.
Right.
The process of formation of the sperms is called as spermatogenesis.
Yes.
So our testes, they accommodate with the external
Right.
temperature.
Yes.
How man in his observation, when it is hot climatic region, they get loose,
Yeah.
and when it is cold, they try
Yeah.
to adjust the temperature by getting
Contracting.
stuck to
Yes.
the
Yes.
body.
Right.
So when there is pooling of blood, then there is rise in the temperature.
Okay.
So it is said, not 100%, but it is said, it impairs in the spermatogenesis.
Exactly.
So we deal it laparoscopically,
Okay.
just matter of 2 holes, daycare procedure,
And it's done.
and the problem
What
is
about
over.
testicular torsion, an emergency that young boys mostly have? So how do you deal with that?
Testicular torsion, if means simply the twisting of testes. Okay, it is an emergency.
Painful.
It is an emergency, and it
Right.
is an emergency. I mean to say, if a boy presents within 6 hours,
Yeah.
then there are chances that that testes is viable. Otherwise, when it gets strangulated, it get twisted,
Once.
it compromises the
The
blood supply of that testes.
Okay.
It gets gangrene. Once he presents more than 6 hours, at times more than 12 hours, then there is high possibility of gangrenous of that testes. Then we need to remove that dead testes.
So are there any causes of like obstructed blood supply to the organ or obstructed nerve supply that are also causing this that you can fix?
There is Clepper Bell deformity that is
Okay.
congenitally
Congenital.
by birth in some boys, then by carrying heavy weight.
Okay.
Okay, this can happen during the sexual activity as well.
Okay.
Yes.
And what about crypt orchidism, where the testes does not descend in a
Yes.
lot of children? Do we fix that as well?
Yes, we fix, but usually it comes in the domain
its
of
own.
pediatric surgeon.
Okay.
If a child falls in the category of pediatric surgery, we prefer that pediatric surgeon should be doing it. But if it comes in the domain of adult, usually it should be fixed in the second or third year of the life once it is picked. There are so many cases that I deal myself.
Right.
They present late.
Right.
I mean in 30s, 35, where we have no option, just the orchidectomy, which means removal of the testes.
That is very sad.
Yes.
So, Dr. Saab, you're doing a lot in gynae as well,
Yes.
right? So, what are the laparoscopic procedures that are being done in gynecology that are
Yes.
actually helping the women?
Yes. Regarding the gynecology, so many ovarian cysts.
Okay.
I can name the hemorrhagic ovarian cyst,
Right.
the dermoid cyst, the cyst adenoma, par ovarian cyst,
Okay.
and then the ectopic pregnancy.
Fibroids as well or no?
Fibroid comes in the matter of uterus. I will be discussing. So,
okay. First ovary.
regarding the ovary,
Okay.
then the tube. I
Right.
mean, the commonest
Ectopic.
pathology is ectopic.
Right.
Okay. Then regarding the tube, infertility workup, where we check the tubal patency.
Yes.
Okay. Then pelvic inflammatory disease,
Right.
where we do the adhesolysis.
Right.
Endometriotic cyst, chocolate color cyst, which
Okay.
is nowadays very, very common.
Right.
And the main contributing factor that is held responsible is the junk food and the adulteration food.
Yeah.
And that contributes about 40 to 45% in female infertility. And then there is, I mean to say, coming to the uterus, fibroid uterus,
Yeah.
Uh,
Endometriosis.
endometriosis.
Okay.
Endometriosis I just mentioned.
Yeah.
Fibroid uterus is most common. And then there is one term which is called HMB, heavy menstrual bleeding.
Right.
I mean, there is female with the heavy menstrual bleeding, there is failure of
Yeah.
medicine. She has to go to hospital for every week
Right.
for transfusion of more than 2 to 3 pence.
Okay.
Then the answer is the hysterectomy, which means removal of the uterus.
Right.
We just remove this uterus with
Okay.
3 holes,
Okay.
and same day patient is operated.
So that is very amazing.
Yes.
When we talk about breast cancer, it is another surgery
Yes,
that
yes.
is done, and since you're a surgeon and specifically a laparoscopic surgeon,
Yes.
you're dealing a lot with oncology, different
Yes.
kind of cancers that
Yes.
might develop anywhere, whether it's
Yes.
a breast cancer or
Yes.
any other part of the body. So how do you proceed with breast cancer surgery?
Initially, when patient comes to us in the OPD, we first take a detailed history of the patient, and then we examine the patient thoroughly, and we correlate the symptoms and the clinical examination. Then we go for certain baseline investigation. Like if a female is less than 40 years, we preferably going for the ultrasound breast, sonography of the breast, and then the armpit. And if she is, 40 or above 40, then we go for the mammography.
Okay.
Because the breast tissue is more dense in young age group in comparison
But a
with the old.
laparoscopic surgery or an approach is available in breast surgery. You don't have to do a complete,
Well,
radical
laparoscopy,
mastectomy.
so far the breast surgery is concerned, no role of laparoscopy.
Okay.
But
So-
there is concept of breast
Minimally
conserving,
invasive, yeah.
breast conservation surgery and breast removal surgery.
Okay.
That we decide accordingly, in which she falls. She falls in young age group, and if there is possibility, we can perform the conservation surgery. We should be doing it.
What about thyroid cancers? Do you
Yes.
perform thyroidectomies and
Yeah,
removing the?
regularly I used to. This is one of my favorite procedures. One of the
But it's
favorite
a very
procedures.
dangerous one.
One of the favorite procedure I love to do is the thyroidectomy.
Thyroidectomy?
Yes.
Okay. So can you tell us about the different symptoms, because it's very rampant in our country.
Yeah.
People have goiters,
Yeah.
hypothyroidism. When does it become an indication for surgery so that they
I
don't?
mean, whenever
Yeah.
it is not functioning properly, either it is hypofunctioning or hyperfunctioning. Hypothyroid is one term and hyperthyroidism is another term. There are a lot of symptoms that patient present in case of the hypothyroidism and in case of the hyperthyroidism. Like the common symptoms in case of hyperthyroidism: sweaty hands, palpitation,
Right.
and then there is weight gain, and then there is abnormal menstruation. In some cases there is hair fall, which otherwise is not very common. So whenever it is under functioning or over functioning,
Yeah.
it gets enlarged.
Swollen. Yes.
It gets enlarged.
Yeah.
It is nothing a butterfly shape or the H shape organ over here.
Yes.
So again, there are different ways of doing it. If a patient is young, we try to conserve some portion of the thyroid so that for rest of her life, she should not be dependent on thyroxine. Recently, I operated on a patient. She came all the way from Chakwal. She was just 15 years old. Very unfortunate that she once was operated at the Chakwal, and then the biopsy histopathology report turned out to be thyroid carcinoma. So then I have to go for the completion thyroidectomy.
And it's okay to live without the thyroid gland and then on thyroxine for the rest of your life?
I mean, this is the vital gland of the body.
very
Whatever we eat, it is under the control, it is under the influence of the thyroid hormone. Okay, we have no other choice if there is cancer, if it is not functioning properly, because it hits different parts of organ in different ways.
Right.
So we need to improve the quality of life. So to prove the quality of life, we need to do what is ideal treatment. So afterwards, he or she can live on a synthetic thyroxine. That's okay.
So being a laparoscopic surgeon, Dr. Saab, you're stressing on early diagnosis and saving lives.
Yes.
So what are the routine investigations that a person should go through so that they are sure that their overall health is okay and there is no underlying oncology or cancer developing in them, and they can go for surgery right away?
This is a very important question. I mean, regarding the awareness that if you ask me question, Dr. Adil, are you healthy? It is not just verbally I am saying that I am healthy. So I must go through some body screening test, which depends again on the genetic predisposition, which again depends on the age group as well. Say for myself and for yourself, we need to go for ultrasound abdomen and pelvis annually.
Oh,
Okay.
see, not many
Yes.
people know that.
Yeah, and in case of female, one should go for the ultrasound breast, okay? And then we should go for the blood CP, liver function test, and the kidney test. We should go for the, urine analysis, because there are so many pathologies that are most of the time silent,
Right.
that you didn't experience any kind of symptoms. Like if you are, God forbid, if somebody is suffering from hepatitis B and C, usually it is silent. In 65% of the cases, it is silent. So to update yourself and to know you are healthy, one of the screening tests is hepatitis B C serology. You must go through this.
So that,
And
because the silent
chest
killer,
X-ray, I would like to say unnecessary exposure to the
radiation
should be avoided. But these are, common screening tests. Nowadays, the diabetes is very common. You should go for the
HbA1c.
HbA1c. Yes.
Thank you so much. Thank you so much, Dr. Adil. You explained everything in so much of depth and detail. It was very, very insightful talking to you. Thank you for your valuable
Thank you
time.
very much.
And as everybody heard out there, we had a very nice, it was a complete comprehensive lecture on surgical conditions, the treatment, how we need to manage them, and how we need to go to somebody as educated and as experienced as Dr. Adil Shafi himself when it comes to our health and especially such surgery. Thank you so much for watching. Inshallah, we'll meet you next week. Allah Hafiz.